And then finally, in terms of the older medications, they're still effective. It's not as though you can't use them, but it's just that they tend to have more side effects. And so nortriptyline is another one that you will also see on those $4 a month formularies. So this is one where the starting dose tends to be lower in terms of starting at 10 milligrams, but the usual dose is somewhere between 50 to 100, and there is also a therapeutic dose range as well. In terms of side effects with the tricyclics, we tend to see a lot more of these antihistamine type of effects, and then on top of it, I also listed here weakness and fatigue as another common symptom that we'll see. Desipramine is another one. This one is not on the $4 per month formulary, so this is one that I would not expect us to really see our populations use as much. But again, you can see that we tend to start at a pretty low dose range, and then we tend to need to have a much more higher usual dose. And again, with all these tricyclic medications, in terms of that side effect profile, these again are like the ones that I mentioned before, where they can cause cardiac arrhythmias, where they can interrupt your heart rhythms if they're at high enough doses. So, so probably for safety reasons, it doesn't make sense to use these as the first-line agents, but at some point, as we're working with our patients, if we find that certain medications are not working, it's okay to use these, but we would probably not suggest them to be the first one to start with. So I don't know if you want to.
Oh, sure. Okay. So how do you choose an antidepressant? I think you go by a lot of ways. You might ask patients what's worked for them in the past. So what's worked for them in the past will probably work for them in the future. What works tends to run in families, so you might ask, well, if your mom or dad or your brother or sister had depression or anxiety, which medication did they use? Did it work? Did they like it? Because sometimes the effects, the beneficial effects, runs in families. You want to ask patients what they want. When patients come to me all the time, and go back to the Coca-Cola analogy, these are different kinds of. These are like colas, especially the SSRIs. And they're more similar than different, although they do have differences. And unless there's some huge overriding reason, I let people choose what they want if there's no financial barriers. And I explain the financial costs to them. The expertise of the prescribing provider. Some of the doctors may not feel comfortable with one thing or another. So, if you're called to make a recommendation or say these are the options, doctors, they're like anybody else. They'll rely on the one or two things they know in a particular class and prescribe it all the time. So, doctors, if this is the only person available, don't try to necessarily push them to something they don't necessarily feel comfortable doing without consultation. Side effects, sedating or activating. So some medications like the tricyclics are definitely very sedating. Wellbutrin, for example, can be, it's quote-unquote more activating, meaning it can make people feel a little bit anxious or nervous when they first start it. Safety and overdose. TCAs are not good for people who are always suicidal because 10 days of it can be lethal. SSRIs, as far as we know, you can take probably a gallon of it, and it won't kill you from the effects of. You could take a bucket of it. You will feel very bad, but you will not die. You will not die. It sounds like a joke, but actually that's something very important to take into consideration if someone's suicidal. Availability and costs, and I think in this population that's a big deal. Like I said, I work with a lot of people who are transient, who are homeless. A lot of young adults who may or may not have homes, and I actually last week I saw one of the young men. He's a young man who emancipated from the foster care system, is transiently homeless, lives with his various friends, motels, and I started seeing him about a year ago for depression. He's 19, and actually I think what made the difference for him was the fact that he has no insurance. For some reason, he lost his Medi-Cal, and I think the big thing that made a difference for him was getting something that was affordable. So we got him citalopram, and he goes to Target, picks up his $4 prescription, and he's able to do it every month. and so he's actually started getting really well. And as a result of getting well, he's been able to take advantage of lots of opportunities. But $4 a month, and he actually gets 3 months at a time now, which is $10, which is, I think, quite affordable. Drug-drug interactions, I think, with the younger people, you're not going to worry as much. With the older people, like Michael was saying, you want to pick what they call cleaner drugs that don't have as much drug-drug interaction, like citalopram or escitalopram. Maximum therapeutic dosages. These I'm not going to go into these in detail just because you have it referenced, but there are maximum therapeutic dosages. Yeah, so for the tricyclics, you can actually check serum levels generally 12 hours after the last dosage, so you can remind a doctor to do that. It has no relationship to whether the person gets better necessarily, but it can explain side effects, and it can also be used to check to make sure that someone is not taking more than they should.
Or taking them.
Or even taking them. That's a good point. That's right. Especially with the older people or younger people, anybody. But yeah, I mean, I think it's most people it's so rare to see somebody on these medications for depression. I see it for incontinence or or for sleep, but I rarely see it for depression. But I think and generally the people who prescribe are psychiatrists, right? At this point. Yeah, exactly. We went through all the common side effects. The sexual dysfunction, actually, I think it's even higher than that, especially for the SSRIs. It can be up to 50%. We can go through that. Managing side effects. Consult with a prescribing provider, team psychiatrist. Are side effects physical or psychological? Well, it's really tough. Like, because I work at a DMH facility, I have to read the Riot Act to people. I have to go through every little. I feel obligated to go through every little thing and write it down. Like you have headaches, GI upset, you get fatigue, you get X, Y, or Z, and not to say that people are. I mean, I feel like people really do feel these side effects, but I think because you're depressed, one's cognitive perception of every ache and pain is magnified about 1,000-fold, and it really limits people's ability to tolerate their physical conditions, I think, for lack of a better word, and to tolerate side effects. So I think it's both physical and psychological. Generally, the way I try to work with this is I, do the weight and support, right? Meaning, if you write it out, it'll pass. The second thing I do is I always cut it back. In other words, I go down by half. So if they're on 10 milligrams of Prozac, I'll go down to 5, especially when I'm starting. And I go up much slower. And like I said, if I do something where there's a liquid available, I will start them on like a drop, and increase by a drop every week. Because really the goal is adherence and long-term adherence, right? And make sure that you get the person on board for a long time. And if that's what it takes, that's what it takes. Temporary dose reductions, you can treat the side effects, and we're not going to get into treating the side effects because that's probably beyond what's going on here.
Is there a drug of choice for the jitteriness?
What?
Is there a drug of choice when they have the EPS?
The EPS? You probably want, if they start having EPS, you want to cut the medication down by half, or you want to just switch to another medication altogether. Especially a depressed person who has jitteriness and anxiety caused by EPS is not a good thing. It's very anxiety provoking. So that's what I would do. Change to a different antidepressant, or change to, hopefully, you'll have the option of doing cognitive behavioral therapy if you take part in this study. That's actually a really good, especially for things like special situations. Pregnant women, for example. Right? So a lot of pregnant women may not want to take these medications, or women who are, lactating.